Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is Seamless MD's CEO, Dr. Joshua Liu. Today, we're joined by our very special guest, Colleen Hole. Ms. Hole is Strategy Advisor for Innovation and Commercialization at Atrium Health. Ms. Hole, Colleen, welcome to the show.
Thank you for having me.
It is such a pleasure to have you on the show today. You've led just truly a really auspicious career that's been centered around the patient, quality, and policy in healthcare. You've been involved in so many innovations with Atrium Health over the years. I want to dig into a bit of your foundations, like what got you interested in nursing and the business of healthcare in the first place?
Well, I'd like to say I was one of those little girls that dreamed of being a nurse and played, nurse with my dolls. That wasn't me. I was actually a senior in high school, and all of my friends were going into business administration. And I thought, okay, that sounds good. I was the first in my family to go to college, didn't honestly have a clue. So I signed up as a business administration major, but then I thought, wait, I'm not a business person, I don't think. I really feel like I want to be in a helping profession. And at the end of the day, I just want to take care of people. So I'm embarrassed to say I was actually watching General Hospital one day and saw nurses glamorized a bit, actually, and, changing the world. And I'm like, no, maybe it's nursing. So I fortunately was able to change my major a couple of weeks before school started. Wouldn't happen today. So I ended up in nursing school. That was about 4 decades ago. And I learned about holistic healthcare then, meaning whole person care, not just, the physical medical aspects of care, and was really disillusioned when I actually got my first job and recognized that it's super task oriented, but mostly it is delivering and checking the box. The whole person part, frankly, there wasn't structure for or time for. So I rarely saw it, which was just always disturbing, even back then. But over the decades, I found myself in leadership positions and really enjoyed the opportunity to build team and develop people who then could take better care of patients. You've always heard, take care of yourself so you can take care of others. Right. I think that's really, really true in the healthcare workforce. And then later, I learned that healthcare is a business and you really have to tend to the rest of it. And unfortunately, it gets really blurry to the frontline staff who perceive that it's all about money. And no money, no mission. True. But I went on and got my master's in health administration and thought, we can do this better. Then I found myself probably 10 years ago or so in population health, kind of an emerging field. And our organization had stood up a division of population health. And I learned about the triple, quadruple aim. I learned about value-based care. I learned, and not that I actually had to learn it. It was intuitive to me, but it put a label on it for me and started looking at reducing unnecessary, low value, and sometimes even harmful care actually is better care. And at the end of the day, it costs less. What a win. So that can look like helping a patient manage their chronic conditions and living better, not just checking the box. They had their annual exam, but how are they doing? How are they living? And when they're living better and they're engaged, guess what? They tend to not go to the emergency department. So that kind of got me rolling in that direction. And then I became fascinated with senior care, partly because I'm getting ready to be one, and saw how poorly and almost inhumanely end of life care looks. And especially in our country. Other countries do it a lot better. So I really led our advanced care planning work at Atrium Health, helping patients be informed, make decisions before they're in crisis, and then finally really got into patient autonomy and the right to self-determination. So healthcare is generally built as a paternalistic, do what we say kind of system, and really interested in shifting the power back to the patient. So that was a long-winded answer to how I got where I am today.
That's awesome. Today's episode is brought to you by DeepScribe, AI clinical documentation that physicians and health systems love, documenting specialty and complex care with ease and precision. Josh, have you heard all the buzz around ambient AI and virtual scribes?
Definitely. Clinicians are spending hours a day on documentation, so improving their day-to-day and reducing burnout is huge right now. You and I have seen quite a few product demos for ambient this year, but I have to say, DeepScribe was one of the most impressive.
Well, Josh, you trained as a clinician. What stood out to you most about DeepScribe?
Well, using AI to transcribe and summarize the clinician-patient conversation is honestly table stakes right now. But a big challenge for CMIOs and CIOs is driving actual clinician adoption. So what really impressed me about DeepScribe is how well it can be customized to different specialties and workflows with dozens of templates as starting points. That would be critical to me as a clinician because I just don't have time to build templates from scratch.
So true. For me, I was particularly impressed by the auditable notes. You can highlight any part of a note, and then DeepScribe shows you exactly where in the transcript the note was generated from, so you can find that evidence right away. That builds trust.
Oh, exactly. Being able to confirm that something wasn't hallucinated is so important for clinician trust and safety.
Yeah, that same attention to detail that led to really high clinician adoption is also resulting with clinicians saving up to 75% of documentation time.
Wow, that's incredible. But how is DeepScribe's accuracy with specialty care or complex cases?
That's the best part. DeepScribe's proprietary LLM, Heal AI, is trained on over 3 million patient conversations. It's then further tuned by specialty and subspecialty cases, making it way more accurate than GPT-4-based solutions. Pair that accuracy with DeepScribe's customization studio to personalize the experience for different clinician preferences and workflows, and it becomes incredibly flexible.
Alan, speaking of flexibility, I could use some yoga myself. Flexibility is key when it comes to working with health systems with so many moving parts. DeepScribe sounds fantastic. Where can health systems learn more?
About your yoga? I don't think they want to. But about DeepScribe, check out deepscribe.ai. That's deepscribe.ai to learn more. It's awesome. Nursing and patient care changed over the years.
Yeah, so a lot. First of all, technology. When I got out of nursing school, I would hang an IV bottle, not bag, an IV bottle, and there was no machine. Now we have, obviously, IV pumps that create incredible safety. It's a computer, basically. It tracks everything. But we literally would count the drops. Our clinician will know what I'm talking about. Count the drops in the drip chamber to get the rate. High degree of error possibility there. And some of these were kind of scary drugs. That's all we had. And so technology began, and pretty shortly after that, we had IV pumps and we documented on paper. Literally, I loved my notes on paper. None of that is done now. That's all built in the electronic health record. And thank goodness for patient safety, we can all have visibility into the care of the patient, no matter who's touching the patient. So I would say tech enablement of care is huge, cumbersome and frustrating at times, but ask anyone what it's like when the computer's down. It's chaos. So we've become reliant on that. I spoke about holistic care and whole person care. There were a couple of decades in there that it didn't feel good at all, at least for me. But I think we've come almost full circle and people are starting to talk again about humanizing healthcare and whole person care. So I think, care was delivered in the home decades ago. There weren't hospitals until post-World War II, Hill-Burton Act. We built hospitals. So we institutionalized it and put all kinds of departments together and structure and order. I see that unwinding, not destroyed, but how do you integrate both tech and structure and frankly payment with person-centered care? Right. That's where I think we come to.
Colleen, I want to unpack something you talked about earlier about how care has changed. I'm actually interested very much in the clinician experience. So it feels to me like decades ago, being a clinician was something that was aspirational, right? It was a career that people were excited to do. And it feels like in today's world, I'm meeting clinicians who are telling trainees, hey, like, this is not a great field anymore. You should consider maybe getting your clinical degree and then not practicing clinically, for example, or seeing folks leave clinical care. I'm curious, what is actually better today about being a clinician that maybe wasn't when you first started? So maybe there are some good things, but then also like, okay, well, what are the really not great things that if we don't fix that, there's going to be a real, crisis with the workforce in the future. I'm curious how you're thinking about how things have changed today as a clinician.
Yeah, there's a lot in there. I think you're right. There, particularly for women, we thought of it as a calling to nursing. Like you could be a teacher or you can be a nurse. And both of those were honorable. Women generally, even doctors, frankly, not many then. Now some schools have more women than men, but certainly not, you're not going to be an attorney, you're not going to run a bank. But I think generally people want to be in healthcare to help people, generally. But you're right. I know an attorney who's going back to nursing school to further her attorney work. There's nothing wrong with that at all. But I do think still as humans, we want to be in a helping profession for a reason. Now, whether that looks like changing a dressing and doing surgery, or a whole host of professions emerged in healthcare around project management and, oh my goodness, the whole tech world. When we started Hospital at Home, we were needing to get thermometers, blood pressure cuffs, and pulse oximeters into the home. And we had no systems to do that. We were in the middle of a pandemic. I had vice presidents who sit behind a desk, come in and help me package these, put them in bags, put instructions in the bag, and put them on shelves so that we could take them into the home. I say that to say, I think even if you didn't enter a clinical profession in healthcare, I hear it all the time. I just wanted to be in a helping profession, and they might be an IT tech. They might, frankly, be in finance. I know very mission-oriented CFOs. There aren't many, maybe, but they are. They're there. They want to be in that profession. So I think that's still true of humans. I think, like I said before, for me personally, in the middle of that 40 years, it felt like it was all about checking boxes and doing tasks. We lost our connection to caring. It was also frustrating. Everybody was coming. It was cool to have mission, vision, and value statement. And they almost flew in the face of us clinicians. It just felt like words on the wall, didn't ring true. So there was this disconnect, a lack of institutional integrity, I've called it, where what you espouse up here didn't ring true at all on the front line, especially if you were running short-staffed and you were doing the best you could. And people were like, sorry, we can't afford another nurse. Again, I think we've come along. I think some of the efficiencies that we've gained largely through technology and learning best practices has created opportunity to staff better, and people don't feel completely overwhelmed. I say all that to say 4 years ago, we were slammed with a pandemic, which changed everything again. And I'm sure you've heard the term moral injury, where our clinicians just felt sucked dry and not able to even care. They had cut off that part. They watched patients die alone and felt impotent to actually make anybody feel better. Again, I think what doesn't kill you makes you stronger. I see a more resilient workforce emerging now than even pre-pandemic. We learned what's possible, what we can do together. Departmental walls were knocked down. People had to work together, like in a code. In the emergency department, you just save the patient. Doesn't matter who's mad at who or whose budget it comes from. I think that taught us a lot about what's possible. So I see us emerging stronger than ever, but I also see professions within healthcare, virtual enabled, that give clinicians new ways to work. And maybe, someone my age, I'm not inclined to stand on my feet for 12 hours a day in an ICU anymore, but my brain still works on most days. So new roles, virtual physician roles, nurses, care managers, they're going to stay in the workforce longer. So I see that as really advancing our very kind of scary manpower challenges. I don't know if I answered that or not.
You did. I just want to comment. I think something you said really resonated with me. You mentioned how, as tough as the pandemic has been, it's made our healthcare, professionals more resilient to have survived, the pandemic. And it reminds me of this phrase, like, hard times like make strong people or something like that. And I think that's a great example of that. As a very, by the way, your comment is like a very positive way to look at all the toils we've had to go through. I really like that, actually. It's a very, very positive lesson for us. I know, Alan, I did want to double click on your work in technology, as you mentioned earlier, and hospital at home. So you've been an amazing champion and leader for hospital at home at Atrium. Love to get your take on how big could hospital at home, I guess, be? Like, I know like most folks started off with, let's say, patients who had COVID and maybe a few other populations, but how far have you taken hospital at home at Atrium? And then how big do you think it could get in terms of populations and whatnot?
One of my favorite questions. We are like most health systems. In normal times, if there is such a thing as normal, we would have started a series of monthly meetings and done market research and hemmed and hawed, and eventually, perhaps months in, built a pro forma and a business plan and presented it and maybe started a small pilot. And that's how we tend to do things in healthcare. We're risk averse generally, and we would have tiptoed in. Had it not been for the pandemic, that's where we would be. Winston Churchill or someone said, never waste a crisis. That's exactly what happened. We had no choice. Failure was not an option. We literally, it's like the Apollo 13 movie where they throw everything on the table and said, this is all we got up there. We got to get these people down. We had community paramedics. We had nurses and physicians on standby because we had shuttered some services. Our EDs were busting at the seams. We were talking about standing up a hospital on a parking deck lot. I mean, it was scary, to be perfectly honest. So what else are we going to do? It was all COVID. We took care of over 2,500 patients that first year, never billed any payer. Just it was survival mode. Keep sick people at home. And they were sick. They would have otherwise been in a brick and mortar bed if we had one. A year in, CMS did a very un-CMS-like thing and implemented the CMS acute hospital care at home waiver, which paid us the same for Medicare, whether the patient was in a bed at hospital or at home. And that was game-changing for a lot of us across the country. It gave us some stability financially to cover the cost of this program. So we implemented that a year in and began to take care of all payers. And we are still payer agnostic because we are, as part of our mission statement, for all. A lot of our patients, 10% or so, pay us nothing still. But we wanted this to be for everyone. One of the criticisms of the model, particularly in Congress, is that it's for the elite. Right. And nothing could be further from the truth. I'll get into that in a minute. But we said, hey, we know how to do this. So we began to refine the model over the next year. We're now at almost 4.5 years in. We've cared for over 11,000 patients. We're the largest program in the country by far. We're running a census of around 50. We are planning to scale to 80 and perhaps 100 by the end of this year because we still have a capacity problem. It's not COVID anymore, but it's a lot of chronic disease. And then layer on that acute conditions like infections, and our hospitals are still full. We're in a growing market. It's a blessing and a curse, but we don't have enough beds. And we could keep, if we had money and time, we could keep building hospitals, but that costs $2.5 to $5 million per bed, depending on how much tech you put in that room. That doesn't make sense. We've got an aging polychronic population where the demand for acute care is only going to increase over the next few decades in any market. So sadly, that population won't be here. And the generation behind it in 30 years is much smaller. So potentially, if we had all the money in the world, we would have overbuilt brick and mortar structure and not need it. So why not develop innovative care models delivering acute care, ideally at a lower cost eventually, and it's patient-centered in their own home. So where can it go? Some would say, and I think it's true, at least 10% and perhaps 20% of a market's acute care beds could be delivered in this model. So if you think of a market, 2,000 acute care beds or so in this market, we aspire to 200. And I think it's totally doable to have a capacity of 200 hospital at home beds.
That's amazing. Can I ask you, in terms of how it is today and how it might change in terms of how patients actually get brought into a hospital at home program with you? So is it a mixture of maybe they show up to the ED with something that you determine is not acute enough to be dealt with as an inpatient right now, but needs at least a higher level of care at home? Or is it more that maybe they're already admitted but you decide, hey, actually we can safely manage this at home instead of keeping you in the hospital? I'm curious, like, what are the different entry points to the program?
Well, it's both of those. The CMS waiver requires that the patient be taken from the emergency department or an inpatient unit. So from the ED, it would be a direct admission to hospital at home. From an inpatient unit, it looks a lot like a length of stay reduction. They still need hospital level care, but they're stabilized. They got their MRI, they got the result, they can go home. What we hope for eventually is the patient could be admitted from a physician office. So if this is a known heart failure patient and we know how they respond to Lasix, what's the value of making them go from the physician office to the ED back home? Nothing. In fact, when I talked about harm earlier, that delays care. EDs are chaotic and infectious. So why not just send the patient straight home? Even better, the patient is at home. They call their physician, or perhaps they call 911 and the paramedic shows up. We know the patient, ideally. We assess the patient, report back to the provider, and we give them their 40 of Lasix right then and don't go to the ED at all. So you would admit from home to home.
Right.
That's where I think we'll go. None of the payers yet are comfortable with that, not the least of which is CMS, Medicare. But I see that happening at someone. But that is one of the requirements of the CMS waiver, and we've chosen to apply that standard set of rules to all payers.
Cool.
It's just easier to operationalize the program if we don't go, well, Blue Cross Blue Shield does this, right, but Cigna does this. So we do it the same for all. But I see it evolving to where the patient can come from anywhere as long as safety nets are in place to fully evaluate the patient and make sure it's safe.
This is going to be a weird question, but maybe not to you, maybe to us it's not weird, but you had this really great point about, because right now I think based on the way it's funded, you have to be sick enough to need to have to present to an ED or be admitted to be in this program. But let's say you were, getting exacerbation of your condition, that really you should get a higher level of care at home, but maybe you're not sick enough to be admitted. But there should be some almost like middle level program where you are getting that care at home, where you are being visited, that should still be funded. But it sounds like right now, unless you actually really need to be almost admitted, you can't quite be in this program. So hopefully at some point, and maybe that's just a funding model change. Maybe if there's more value-based care, there would be a need for more of these at-home models in general and more home visits in general. Maybe that's what we really need, a reimbursement, funding model change. That's always the obvious answer, right? Value-based care. But it seems like something in the middle at some point is really what's needed. So
we're developing that very thing. So if you think about a continuum of home-based care where hospital at home, inpatient level care at the highest level, all the way to what we call Primary Care Connect, which is a team of virtual nurses who just check in some regular cadence with mostly chronic condition patients. Okay. Hey, Mr. Smith, this is Lisa. I'm checking in with you. Have you weighed yourself today? No, I just didn't feel up to it. You know what? I'll hold. You run away yourself. That kind of touch is very preventive and effective at keeping the patient out. So there's this continuum. But in the middle of that is home visits by a community paramedic or an RN. Home health, the traditional home health. All of these live within this spectrum of home-based care, and we're beginning to work to connect them. The patient shouldn't have to experience a break in care to go from one to the next. It should feel like Atrium Health is taking care of me. And it might even be the same nurse. The hospital home nurse might be the same nurse as the home health nurse, potentially. But payment is what's still uncertain. So we are developing an outpatient, and I use that loosely, conjures up different things. But from a billing perspective, there are certain, and not much, billable as an outpatient. Using this same array of services, but frankly, we'd have more flexibility to do what the patient needs, no more, no less. For example, currently the waiver requires that we visit the patient twice daily in the home. That's appropriate for 99% of our inpatient patients. But this patient, to your point, might really only need to see once, and nurse is going to check on them by phone 2 other times. And they've got remote patient monitoring in the home so they can hit a button for help. You can do the model differently with more flexibility if we weren't so worried about payment. So it's evolving.
Yeah, it's funny, but it's almost like with payment models, they're kind of, what do you call it, designing to like the lowest common denominator. So they're worried about the people who are going to skimp on care and saying, make them do at least 2 visits. It's like, well, if someone's actually doing it right, maybe it's 3, maybe it's 1 and a phone call, like you said, but they're so worried about people being cheap about it or under caring that it almost like penalizes the ones who are actually going to do it the right way, unfortunately.
That is beautifully said, because, and I get CMS's position, we've got to set a bar to which all must measure up to, but it takes away any, honestly, not any, but a lot of the critical thinking of what actually does the patient need, and allow us. And that's when you get into value-based care, as you mentioned. We're going to do exactly what they're needed, sometimes a lot more than we're going to do for this patient, but this patient doesn't need this, so let's not do that. They don't want it anyway.
Today's episode is brought to you by Seamless MD, which enables health systems to digitize patient care journeys, leading to lower lengths of stay, readmissions, and costs. Josh, you used to be a doctor. Did you ever feel like patients showed up unprepared for surgery? Or maybe you felt like you were sending patients into a black hole after discharge?
All the time. We give patients paper and verbal instructions, which are so easy to forget and really hard to follow. And we have no idea what happens to them outside the hospital. So what happens? Well, because we worry about them, we keep patients in hospital longer, but that drives up length of stay and lowers throughput. Plus, after they leave, patients get readmitted for infections and all kinds of problems that we could have just caught earlier if we monitored patients.
What if I told you there was a way to give every patient a virtual companion so you could automatically engage and monitor them through a surgery, a cancer journey, or a chronic care journey, and drop the length of stay, increase throughput, and lower readmissions?
Gosh, Alan, that would be amazing.
So that is exactly what Seamless MD does. It allows health systems to engage patients on their own phone, tablet, or computer with automated reminders, education, and symptom monitoring. Basically a GPS through any healthcare journey.
That sounds fantastic, but does it actually work?
It does. Health systems have done over 40 studies and evaluations showing how they use the solution to reduce length of stay by 1 to 2 days, readmissions by up to 89%, and costs by over $1,000 per patient.
But how does that work with my EHR?
That's the best part. Seamless MD is the only solution in this space with direct integration partnerships with Epic and MyChart, Oracle Cerner, and Meditech.
Well, I am getting a colonoscopy soon, so I really need something like this. Where can my health system learn more?
Well, Josh, thanks for letting me know. Your health is very important, and endoscopy is just one out of the 50 plus out-of-the-box care plans available today on Seamless MD. Go to www.seamless.md. That's www.seamless.md to learn more. Curious, Colleen, you've now had this program for about 4 years. And like you mentioned, it expanded beyond COVID patients. You're now doing chronic care. What have been, if any, some of the biggest challenges along the way or some of the growing pains with the program over the 4 years?
Yeah, payment. It's not the reason we're doing it. It never was the reason we're doing it, but it sure is helpful to have funding to cover it. And we, Atrium, and actually Advocate, are all in. We're going to figure this out. They're further along value-based care in the Midwest than we are in the Southeast. We're still largely fee-for-service, but trying to figure that out. And it's not just commercial payers, it's governmental payers. So I mentioned the CMS Medicare coverage. But Medicaid, state to state, varies widely. At last count, there were only 8 of the 50 states Medicaid covering. North Carolina happens to be one of them, thankfully. But that was a lot of advocacy and effort to try to get Medicaid coverage in the state. Massachusetts, frankly, is leading the way in this space. Their Medicaid program actually partners with health systems to advance health equity, which, as I mentioned earlier, that has been one of the issues perceived, that it perhaps advances health inequity, that it's only for the elite. So I do a lot of governmental advocacy work at both the state and federal level to help legislators who vote on policy, help them understand this is a better way to do this, not for every patient, but for many. And then I think the commercial payers will go, oh, okay, the government's on board, we're coming along. And they are, but it's not all the way there. The other challenge is for us, we were often called the COVID virtual hospital. Like, oh, it's COVID. Yeah. Even 4 years later, I run across people who think it's still just for COVID. And, we have many residency programs in our system. So every year in July, we have to re-educate our attendings and our residents about hospital at home. Don't forget about hospital at home. I mentioned capacity. So we're still in a capacity crisis. It's still amazing how people forget, hey, we're here. We could take dozens of your patients. So we constantly have to educate, remind, go to staff meetings, send emails, and work with stakeholder groups to keep it front of mind for non-COVID. There's also a disincentive, frankly, for nurses, and this hopefully doesn't offend, but I've been one, so I'm allowed to say it. If you're a nurse or a physician on an inpatient unit and you're already drowning, what is your incentive to transfer that patient to hospital at home? There really isn't one. It's probably the most stable patient you have. If you send them out, you're going to get a sicker patient from the emergency department. And it's just easier to round on that patient and transfer them out or discharge them in a couple of days. So that's just human nature. Doesn't make them bad people, but that's a challenge. And then just related to that is just finding the patients. I mentioned, I truly believe up to 20% of patients currently occupying inpatient beds are probably eligible. And it's not just medical patients, it's post-op surgical patients who we're just tracking labs or waiting for their GI tract to wake up. They don't need to be tied up in a hospital bed. So it is an ongoing effort to find these patients. And then the last thing I'll mention is just navigating the gray. This is still emerging. So we're a certificate of need state that controls bed licenses. They don't know what to do with this. How do you count those beds? Do you count them against the allotted inpatient beds of a health system? Do we think of them as outpatient beds? Our compliance folks, they've come along, but they like black and white. This is gray. They want to refer to rules and regs that are set in stone and hospital conditions of participation. Truth is, some of it isn't written yet. And until some of that happens, and there's a lot of work underway to define what are the care standards for these programs, what are the quality metrics and benchmarks that need to be established, it's still navigating the gray. So I would call all of those challenges, but they're not insurmountable.
First of all, that was an amazing answer. I mean, I'm learning so much about a very unique perspective. Do you know the answer to, with, let's say, the CMS readmission reduction program and the penalties, if a patient is admitted to a hospital at home program, let's say from the ED, and then you discharge them from it at some point, they get readmitted within 30 days to, let's say, the acute care facility, is that considered a readmission or is it not because they were never in a, it is?
Yeah, because our hospital at home patients are technically inpatients of the facility of origin, which is another, constantly with stakeholders, hospital administrators, oh, you're dinging me on your readmission. Guess what? Our readmissions are lower than brick and mortar readmissions. So we're actually going to help you. Our mortality's better, our readmissions better. So the quality metrics are the same, in most cases better. Patient experience, way better. So we actually help. But yeah, they ding the facility because the patient is an inpatient of the unit. So we have 7 hospital at home waivers, and then we have 3 other hospitals that are on the license of 3 hospitals. So we have 10 facilities we draw from, and all of our quality measures go back to the facility where the patient originated.
It's fascinating. One of the things that you brought up that really hit home was this comment around clinicians already drowning on the units. And so there's that weird misaligned incentive around, well, do I really want it to transfer a patient to hospital at home who is relatively stable and then get some incredibly, even sicker patient. And so I feel like I'm drowning even more. And I don't know if there's a good answer to navigating that, especially in the current times where we're so worried about clinician retention and burnout. And I hear often from clinicians, to your point, and this is not just for inpatient care, but even outpatient care, sometimes it's good to have a mix of like easier cases, right? Things that aren't as cognitively taxing as a provider.
Yes.
You want that balance in your day. So I don't know if there's a good answer to it. Because everyone I think talks about, as people who are in healthcare keep talking about, oh, wouldn't it be great to let every clinician operate at the top of their license 24/7? But as a clinician, you're like, maybe I don't want to do that.
I don't want to. Yeah. I managed ambulatory practices for a number of years in this space of 40, and I didn't love it, frankly. It felt like herding cattle to me. It was about RVU generation largely, but I heard that very thing. An internal medicine physician loves that hard patient, but not all day long. They want a couple of them to tax their brain and keep their skills up, but it's really nice to get, a flu. And, so it's true on the inpatient side as well. I don't know how you perfectly align incentives. You can't ethically or even by law incentivize length of stay reduction, and because for obvious reasons, but it's rapport building. We've got incredible support with our hospitalist leadership team, and they recognize how it's on all of us to decompress the emergency department. I mean, a full ED is not the ED's problem alone. It's the whole house. And so it is an ongoing trust building, relationship building effort. That's why I do a lot of coaching and counseling around this model. It is not just about turning on technology and hiring staff. We are such an integral part of the health system. You can't operate in isolation. You've got to constantly connect, reconnect, and drive people back to our for all mission. That sounds really mushy. But if we believe in our hearts, and we do, that this is for all and we are one, then we all move in one accord. And that doesn't happen naturally or easily. It takes a constant, zealous effort to stay connected. It's as important as anything we do.
And I think you're right, because at the end of the day, what's going to convince people to do this, and even let's call it do it against what their rational self-interest, around keeping a healthier patient in the hospital would be, is because it's better for patients. And at the end of the day, clinicians want to do what's better for patients. And then to your point, you remind people, this is why we're doing it. Everyone's on board. So it sounds like there is constant work to promote and remind and evangelize what you're doing, because people forget.
They do.
Yeah,
definitely.
One of the things that I remember hearing from you at the HIMSS conference this year, and you were on a panel talking about, hospital at home, you mentioned how the impact on families and psychological well-being when it comes to hospital at home is, I don't think well talked about. And you mentioned how hospital at home allows your patients to not worry about what's going on with their family and their kids, I presume because they're at home still around them. Can you talk a bit more about that concept and what you've learned about the impact on families with hospital at home?
Yeah. One of the criticisms, I hate the word criticism, but an issue that gets raised is caregiver burden, that you're just transferring all the burden of caring to the family by putting the patient in the home. That can be true. If you have a couple, 80-year-old married couple, and one is fairly frail and the other one needs hospital level care, it's probably not going to work. But you shouldn't throw the baby out with the bathwater, because equally there's a caregiver burden by having a loved one in a brick and mortar hospital. Just think about the rural community. And so we're a big city in this Charlotte, Mecklenburg County, but as soon as you cross the state line, you are in rural America in any direction, north, south, east, west. And a lot of elderly and lower socioeconomic patients live out there. So their access to care is already challenged. They have to come into town to receive care. If we go to them, how much better is it for a large number of them? Many of them have small gardens to tend to. They have pets that they will desperately miss. They have neighbors and churches that surround them and can lean in and support the patient. But if that elderly gentleman ends up in a Charlotte hospital, his wife may not be able to drive in to see him. The neighbors sure aren't going to. He's lonely and experiences all the risks of hospitalization, like delirium, insomnia, risk of falls, infection. They don't eat, they don't sleep, they don't move. So in every way, probably this patient's going to do better at home, and we'll send in the support that is needed to take care of them there. But again, it's not for every single patient. There's the issue of respite care. Sometimes a hospitalization is rest for the family who've been taking care of them all along. So all that to say, you got to evaluate every scenario. We've had patients say, you would have had to tie me to this stretcher to keep me here. I'm going home.
Yeah.
Occasionally, we've had a patient say, I'm out of here. And the wife comes in and says, oh, no, you're not. So you got to look at the whole family structure. The other issue is children, as you mentioned. For a mother to have 3 small kids at home and have to be trying to figure out how to go visit or be with her loved one in the hospital, really hard. And so burden, let's not throw the word around as if it's one thing or another. You got to look at how to support that family unit in the best way possible. I also mentioned, and I heard this from Lee Fleischer, who was the head of CMS for years, when you transfer a patient from the ICU to a step-down unit, no one says, oh, you're delivering less care. That's not health equity. Well, the patient requires less care. That's an appropriate transfer. This is no different than that. If home is appropriate, that level of care is appropriate, that's great. That's for all. And as I mentioned, we've got 10% of our patients self-pay, no pay, another 14, 15% Medicaid, and a 50% Medicare. These are not the rich, elite people that we're taking care of. It's for all. And I'll mention this, social determinants or social drivers of health. We have very limited visibility into the real truth of how patients live from our traditional structures, whether that's a doctor's office, an ED, or an inpatient unit. We do the assessment. We do a risk assessment. Do you have food? Are you able to afford your medicine? We ask all of that and we write it down. But our ability to actually do something about it is incredibly limited. And we don't get the whole truth. It's embarrassing to admit that you don't have food. When we go into the home and we see the refrigerator is empty, we see the pill box is empty, we see that there's no air conditioning and it's 95 degrees in Charlotte, we can actually do something about it. And that's true, holistic, whole person care that no traditional structure allows us to do. So we can assess and address the real issues that are keeping patients from living well.
That's amazing. Can I ask you, in order for that to work in terms of, like, let's say you actually are able to deliver home care and you see the living situation and the impacts of those social determinants on the patient's health, is it safe to say that there has to be that right? You can call it a value-based care funding model or some other immersive model where the care team actually has the aligned incentives to not only care to improve those things, but have sort of the funding model to even just like afford the interventions you need to address that. You know what I mean?
Yeah.
Does that only works like if you're in an ACO or something like that, or how do you make that work?
So it's largely about partnerships, honestly. We've got food banks. We've got, and I won't name names, but we've got home improvement organizations that want to partner with us to put in a shower bar to keep the patient from falling. Yep. I'll mention Habitat for Humanity and like organizations are very interested in helping identify patients who have a need. And we've recognized about 25% of our patients need some home intervention to make the home safer or more livable. Might be a ramp, a shower bar, any number of things, a leaky roof. Those are things, every organization wants to do better in this space, whether they're healthcare or not. So it's about aligning incentives with partners, and the potential there is huge. I don't think we've begun to realize all of it. Now, it's harder in rural communities that have fewer community agencies. In Charlotte, we've got Uber and Lyft and food banks and MedAssist and all these programs, fewer in rural communities, but still, I think that is largely the answer. And then some of it we do fund ourselves through social workers, care managers, et cetera. I think that is the answer. It's partnerships.
So, Colleen, just being mindful of your time, I hate to do this, but we have to flip over to the Fast 5 lightning round. So this is just 5 quick questions to get to know you better. First question of the lightning round, what is your favorite book or book you've gifted the most?
So this is really old. It's 25 years old, but it's The 7 Habits of Highly Effective People by Stephen Covey. I read it in my 20s. It was life-changing for me. And not that it was new concepts, but validated everything I believed about the human experience and living well as a human on the planet. And I've given many, many talks on it and given it to everybody I know.
I love that. That's great. Question 2, who is a person either dead or alive who you'd love to meet?
I would love to meet my 13 generations back ancestor, William Davis, who came in the late 1600s from Wales.
Wow.
I love genealogy. It just fascinates me. I think everybody ought to care where they came from. I would love to talk to him or others. What drove that person from the relative safety of Wales to cross an ocean to a complete unknown and start building schools and stuff? Like, I would love to spend time with really any of my ancestors.
Oh, fascinating. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
That's an easy one. Super strength, but not just physical. I think that's too late in life for me to be super strong, but physical, mental, emotional, and spiritual strength. All of those together, that's resilience. And that's when you're strong, I think you can help others more.
Yeah, I love that. That's great. Question 4, what is something in healthcare you believe that others might find insane?
It's a funny question. And I did prep my brain on that one. I spoke to it a little bit before. How incredibly powerful caring is. The human part. I don't know if you know Atul Gawande. He's an incredible writer, futurist, provocative. I love him. And he said, the notion that human caring, the effort to do better for people, might make a difference can seem hopelessly naive, but it isn't. And it's true. And there's research that shows if just one person cares about you, it can change the course of your life. So I think no matter how incredibly sexy technology and all of that is, at the end of the day, it's caring.
Yeah, I love that. Last question that we have, if you could travel back in time to any event or moment, what would it be and why? And you can't say 13 generations back when you can't reuse that.
I'm not going to go back that far, but I am going to go back to January the 30th of 1939 in rural West Virginia, middle of winter. There's a small building above a garage, a room, where there's no running water and no electricity. And my 17-year-old grandmother birthed my dad.
Oh,
no electricity, no running water, middle of winter, rural West Virginia. I would love to go back, and she was a hero to me anyway. How did that happen? In today's time, that baby would have been in a NICU. She would have been dismissed as a 17-year-old. She was married, by the way. But that was done at home with no resources. This family would not have qualified for hospital at home. We would have said, oh, too risky. She was incredible. And so what is the strength of that person? And could I have just a tiny bit of it? But that fuels a lot of my passion for humanistic, person-centered, home-based care.
I love that. Yeah, great tie into home-based there. That's fantastic. Well, thank you so much, Colleen, for spending the hour with us. That's a wrap for this episode of The Digital Patient, unfortunately. You can follow us on Twitter if you like the show at SeamlessMD. And if you like the podcast, you want to learn more, you can visit www.seamless.md. Colleen, again, thank you so much for spending some time with us and sharing some wisdom and honestly making the world a better place with all that you do. It's been incredible. Thank you so much.
Thank you for having me. My pleasure.